So possibly the most common bowel elimination problem we see is constipation. So constipation is defined as difficult, infrequent passage of hard, dry stools. Frequency alone doesn't determine constipation. Some people may pass stool every 2 or 3 days, but if it's not difficult and the stool's not hard and dry, then that's considered normal. What are the causes of constipation? There are a lot of things that contribute, and most of the patients who have difficulty with constipation actually have several contributing factors. Frequent use of laxatives is a major cause. Aging, because the gut slows down, our mobility slows down, inadequate fluid, inadequate fiber, immobility, a sedentary lifestyle, pregnancy, medication effects. And then we have people who, even if they're doing all of those things right, they're not, they don't have those lifestyle risk factors, they still have constipation. And that's called idiopathic. Typically, when we are dealing with constipation, we want to start with lifestyle. Okay, if we're trying to manage, we want to start with lifestyle. So some basic things we want to do to remember: laxatives are contraindicated if your patient does not have bowel sounds. So when you auscultate the abdomen, if there are no bowel sounds, you don't give a laxative. That means they already have an obstruction, most likely somewhere. Their gut is not moving. And so if you add stimulation to it, you can actually cause bowel rupture. We also want to start with less intervention, or with the least invasive interventions, and scaffold those. So we want to start with increasing fluids, fiber, and activity. Encourage that patient to move, get them drinking fluids, get some fiber in their diet. The next step would be bulk forming laxatives, like fiber or polyethylene glycol, which is Miralax. They hold water in the stool to provide bulk and keep the stool softer, but they don't actively stimulate the bowel, and so they're less likely to cause dependence. The next level would be stool softeners. Docusate is one of those that keeps fat in the stool and pulls water in the stool, and so it tends to keep the stool softer, again, without stimulating the bowel. Stimulants are the next step, and those are things that irritate the bowel and cause peristalsis. One of the most common is bisacodyl, and you'll see it in over-the-counter laxatives as well. Suppositories are laxatives that are administered or medications administered rectally. The most common reason for that is to administer a laxative, but there are some other meds that can be administered rectally for absorption. Suppositories may be either lubricant or stimulant. There are glycerin suppositories that are used to lubricate the stool. Those can be helpful if someone has an impaction. The physical insertion of the suppository also stimulates bowel function. But there are also bisacodyl suppositories that both lubricate and stimulate the bowel. Enemas are given for different reasons, but most commonly to clean out the lower bowel. A tap water enema distends the bowel to cause evacuation. So this distends the bowel. It also, you've got all of that. If there's any stool sitting in the bowel, it can soften it, but it also gives it some water to move in. But if we do tap water enemas too frequently, we risk electrolyte imbalances, because the patient may reabsorb a lot of that water and not have enough electrolytes to balance it. A saline enema may actually pull water into the bowel, which would cause evacuation. Soap suds enemas irritate and distend the bowel and cause contractions. So they're a stimulant. Lubricants can soften the stool and lubricate the bowel or the rectum. Sometimes lubricant enemas are used before disimpaction to try to soften the stool up and make it easier. A medicated enema may be used to treat a local infection or a parasitic infection in the rectum. So if we have a patient who's having chronic constipation, or who's had a severe impaction and needs to retrain their bowel to function properly, these are the things we want to do. We want to encourage them to set aside daily time to defecate. It's most effective if that's after a meal. We want to make sure they're getting adequate fluids and fiber. Make sure that they have privacy for defecation. Encourage them to use an elevated toilet seat or a footstool so that they're in a better position. And we usually want to have escalating interventions for no stool. An example would be the second day without stool, they get a Milk-A-Mag. The third day, they get a suppository, etc. Patients who have chronic constipation may be on bulk forming laxatives daily until they have regular stools for several weeks, and then that's gradually decreased. With a chronic impaction, the rectum becomes stretched and the nerves are desensitized. And so that impaction will keep happening again until the rectum returns to the normal size. So we've got to keep that stool really soft. Okay, the next one we're going to talk about is paralytic ileus.